Hello there. Are you okay? Thanks for joining me. My name is DrRajiv. This is my education channel, YouTube Surgery and Orthopedic Education. Welcome back to another session of lessons. Today we shall talk about the complex nature of evaluating a case of traumatic head and brain injury. There is a lot of stuff to deliver about this topic, so make sure you guys to hang in till the end. I am going to start this with an introduction. During the evaluation process, a clinician typically assesses the mechanism and the severity of the illness. Typical approaches to determining severity early after injury include clinical examination, assessing the presence of altered consciousness or loss of consciousness, assessing the presence of post-traumatic amnesia, deciding the Glasgow COMA scale score, and neuroimaging. Traumatic brain injuries may range from mild, including concussions, to severe, including coma and death. Patients with suspected TBI should be carefully monitored for hypoxemia, that is less than 90% arterial hemoglobin saturation, hypotension, that is less than 100 mm Hg systolic blood pressure, hypertension, that is 150 mm Hg systolic blood pressure or higher, hyperventilation, that is end tidal CO2 less than 35 mm Hg, and hypo or hyperthermia. The history of traumatic brain injury (TBI) must be obtained from eyewitnesses and paramedical team. High energy mechanisms include falls from a height or high speed road traffic accidents. These cases need careful clinical and radiological examination to exclude associated multi-system and spinal injury. In RTAs, victims' transportation time and evidence of hypoxia or hemodynamic instability at the scene are important data to obtain from the paramedics. Many a times falls and crashes leading to head injury are caused by a previous medical problem such as a stroke, myocardial infarction, and hypoglycemia, which may need different treatment algorithms. History of anticoagulants and platelet medications should be checked, especially the need for platelet transfusion or anticoagulant reversal if surgery is required. The patient's whole medical background should be checked, including history of allergies, diabetes, cardiovascular status, and any other medications. The history of fits, alcohol intake, or chest pain also must be obtained from eyewitnesses and the paramedical team. A specific inquiry should be made for any loss of consciousness after injury and for its duration. The GCS score and the state of the pupil at the site of trauma and on arrival in the hospital should be obtained and documented. These should also be checked regularly after that. The deterioration in GCS score is an important indication of developing secondary injury. It is also useful to assess the extent of memory loss for events prior to the injury called retrograde amnesia and for events afterwards called anterograde amnesia. Patients with severe traumatic brain injury (TBI) by definition present in coma. Such patients should be intubated at the scene because they have suppressed respiratory function due to the brain injury and or inability to protect the airway because of the depressed level of consciousness. Trauma patients with TBI must be assessed for the presence of other injuries. The management of the bleeding from a scalp laceration is a part of the primary survey because the blood loss can be excessive and fatal. One should check for the pupillary reaction to bright light, level of consciousness, and for any focal neurological deficits. The Glasgow Coma Scale (GCS) and pupillary responses are well-known prognostic factors in traumatic brain injury (TBI). Gross neurological deficits such as paraplegia should be excluded during the primary survey before intubation. Blood glucose levels should also be measured immediately because hypoglycemia may turn life-threatening and it is easily treatable if recognized in time. Pupillary reactivity is one of the most important parts of the neurological examination in patients with traumatic head and brain injury. The pupil size should be measured in millimeters and the reaction recorded as present, sluggish or absent. The normal pupillary response shows the normal functioning of the optic nerve and oculomotor cranial nerves. A bright light is thrown towards each eye twice, first to assess the direct response of the illuminated pupil and then again to assess the consensual response of the contralateral pupil. Uncal herniation produces a sluggish enlarged pupil due to compression of the third cranial nerve. It becomes dilated and fixed if compression continues. A definite pupillary change indicates injury anywhere in the optic pathway made up of the optic nerve, the oculomotor nerve, and the brain stem. In skull-base fractures, direct ocular trauma or oculomotor nerve injury can cause mydriasis or dilated pupil presenting from the time of injury. Pre-existing Holmes eddy pupil, Horner syndrome, and cataracts should be excluded as these may complicate the assessment. The absence of brainstem reflexes like corneal and gag reflexes after adequate resuscitation indicates a poor prognosis. The Glasgow Coma Scale was first published in 1974 by Tisdale and Jennett as a clinical scale to assess a patient's depth and duration of impaired consciousness and coma following a traumatic brain injury. The Glasgow Coma Scale includes three parameters. Number 1, best eye response. Number 2, best verbal response. And number 3, best motor response. The score is determined by the sum of the scores in each category. The total coma score has values between 3 and 15, with 3 depicting a deep coma and 15 depicting a normal state of consciousness. Serial findings should be recorded on a coma scale chart. This enables observations to be clearly communicated and the trends rapidly appreciated so that any improvement or deterioration in the patient's condition can be seen. In addition, scores can be documented numerically as a shorthand to quickly record findings such as E1, V4, M6. The shorthand numbers can also be added together to give a total coma score like E1, V4, M6 equal to 11. The total coma score provides a summary of the severity of patient's condition, but this score does not give a more detailed description of each response category, which should always be recorded separately in addition to the total score. Calculate the Glasgow Coma Scale score as soon as possible and document it clearly. After primary survey and resuscitation and as soon as the patient is stable, a more detailed secondary survey should be done with particular attention to head, neck and spine. The Glasgow Coma Scale and pupil status assessed in the primary survey should be reassessed at the secondary survey also and regularly thereafter. After the rapid neurological examination and the Glasgow Coma Scale score are recorded, signs of external trauma to the head and neck must be looked for. This sometimes requires clipping of hair to determine the nature and extent of scalp abrasions, contusions, and lacerations and the presence of open depressed skull fractures within lacerations. This inspection and palpation of the scalp should be done to find out any subgaleal hematoma and scalp lacerations, which may bleed profusely and may overlie fractures. The face should be examined for evidence of fractures of the orbital rim, zygoma, and maxilla. The presence of mastoid ecchymosis or battle sign or bilateral periorbital bruising known as raccoon's eye or panda eyes are often found after skull base fractures. The calvarium should be palpated for hematomas and deformities indicating closed skull fractures. Periorbital edema makes the eye examination more difficult. Head elevation, application of iced saline-soaked gauze pads over closed eyes, and the use of instruments to avert the eyelids may be helpful in the examination. Extraocular movements should be checked as soon as the patient obeys commands. Cranial nerve palsies may be due to impingement in the orbit, compression within the cranium, or primary injury to the cranial nerve nuclei. The facial or vestibulocochlear nerve injury is associated with skull base fractures. Midbrain or brain stem lesions may lead to gaze paresis, disconjugate gaze, or roving eye movements. Gaze deviation may indicate the presence of seizure activity. The presence of hyphema and subconjunctival hemorrhage indicate direct trauma to the eye globe, and conjunctival petechiae may indicate hypoxemia. Also look for papilloedema and retinal detachment using an ophthalmoscope. In devastating injuries, the presence of oculocephalic and oculovestibular reflexes should be assessed in order to confirm or exclude brain stem death. Otoscopic and specular examination should be done to look for the presence of hemotympanum or external auditory canal hemorrhage. Associated injuries, for example, fracture, ruptured tympanic membrane, or trauma to the ossicles and other structures of the ear or nose, may also become evident by this. The evidence of CSF otorrhea or rhinorrhea indicates a skull base fracture and dural tear, which are risk factors for later development of meningitis. Most skull base fracture associated CSF leaks resolve spontaneously and do not require any specific treatment. Epistaxis must be looked for and controlled. Severe head and brain injuries may present with an associated cervical spine injury in up to 10% of cases, so it should be actively excluded. These patients should be put in a hard collar until any fracture in the neck is excluded. In road traffic accidents or falls from a height, thoracic and lumbar spine injuries also must be excluded. Limb tone, power, reflexes, and sensation needs to be examined before intubation for ventilation to identify any spinal injury, because after intubation this assessment will no longer be possible. In an awake patient, a per-rectal examination is also necessary for assessing anal tone, anal sensation, and anal wink. Log rolling of a patient is needed to check whole spine for steps and tenderness and for per-rectum examination. Priapism is a strong indicator of severe cord injury even in intubated patients. The examiner should maintain a high index of suspicion for blunt vascular injury in severe cases. This should be suspected in appropriate clinical settings such as unilateral headache, lucid interval followed by neurological deterioration, isolated dysphagia, monoparesis in alert patients, neck hematoma, ecchymosis or crepitus, Horner syndrome, and neurological deficit unexplained by brain-computed tomography. Risk factors for head injury associated cerebrovascular lesions are cervical rotation hyperextension injury, Glasgow COMA scale score of 8 or less, a specific mechanism such as seat belt injury or hanging, a skull base fracture especially involving the foramen lacerum or carotid canal, Lee for 2 and 3 facial fractures, and cervical spine fracture.